So welcome to our listeners, and thank you very much for joining us for another episode of Scoliosis Dialogues. I'm John Vorhies from Stanford, and I'll be your host for this episode. Today I'm joined by some of the brass of the IMAST Planning Committee. Our goal here is to give you just a little sneak peek of what's in store for attendees in early April in Miami. Coming up April 6th through 9th, IMAST is going to be having its first in-person meeting in the past 2 years, and we're really excited about it. It's going to be a hybrid of in-person and virtual content. So we're going to talk about a few of the can't miss sessions and what you should expect. Online advanced registration is closed, but in-person registration is open and you can register when you arrive. And of course, virtual registration continues throughout. There are going to be 75 podium presentations, over 90 posters, and that was selected from a big pool of over 500 submissions. So it's sure to have a good lineup. By way of introduction, I'd like to start by introducing the people I'm going to be interviewing today. So we have Ahmet Alanay, who is the current chair of the IMAST Committee, and he comes to us from Acıbadem, Turkey. We also have Stefan Parent, who is the chair elect of the IMAST Committee, and Dave Skaggs, who's the immediate past chair of the committee from Cedars-Sinai in Los Angeles. Ahmet, would you like to start us off by telling us what you're looking forward to about this meeting?
Yeah, John. So the long-awaited day is now approaching for the first face-to-face IMAST meeting after 2019 Amsterdam meeting. So we all look forward to this important meeting with great excitement, especially to meet our colleagues this time face-to-face. I just want to emphasize why this meeting is important, because this meeting is an international meeting for the advanced spinal techniques and technologies. So, of course, as usual, the whole focus will be on innovative techniques and new approaches in different fields of spinal surgery. Why is it important? Because for us, spine surgeons, new techniques, technologies mean new journeys, and new journeys are full of challenges. While some of us are hasty in putting these innovations into our daily practice, some of us are a little bit more conservative. But in the end, what we are all looking for is, of course, an evidence to start or quit these technologies invented to improve our patients' outcomes. So scientific publications, of course, are having a great importance in creation of these evidences, but sometimes it may really take a very long time to come to our attention. And international scientific meetings like IMAST, where the early results are presented by the inventors or by the experts pioneering these technologies, followed by long discussions, critiques by the participants and the faculty, are really very important and the fastest way to reach the new information. So, some innovations are permanent while others are abundant. But at this meeting, generally speaking, almost all the innovations you are curious about, such as non-fusion scoliosis surgery, surgical treatment of sacroiliac pain, which may be an important source of pain that we think we usually neglect, and robotics in spinal surgery, the current status of minimally invasive spinal surgery, patient optimization, and the use of patient optimization, artificial intelligence for better patient selection, preparation, and getting successful outcomes, and new approaches for the treatment of spinal tumors, especially the metastatic tumors and trauma, as well as cervical deformity problems, especially in children, because these are the conditions that we rarely see in our practices, the cervical deformity problems, and all the surgical solutions for cervical problems in children and adults will be discussed in details in this meeting. So I think this will be a really very nice, very exciting meeting full of new information about new technologies.
Yeah, thanks for that. I think it's really important. You highlighted the sort of thematic differences between IMAST and SRS and how IMAST is really geared towards introduction of new technologies. And one of the things that I've noticed on the program, especially in the past couple of years, has been not just presenting scientific reports of new technologies, but also experienced surgeons giving advice, mentorship, and guidance for how newer surgeons should help incorporate those techniques into their practice and when. Some of that comes in the form of lectures, but a lot of that comes in the form of interactive sessions. And I think we're all excited about the interactive sessions happening in-person settings because conversation is so much easier. So I wanted to shift and ask Dave Skaggs about some of the sessions he's excited about. Can you tell us about any particular can't miss session for you or what you're looking forward to, Dave?
Yeah, John, I'd really like to touch on what you just said. That is so true. That the biggest learning in a meeting is not necessarily sitting through the session, but the discussion you have afterwards, whether it's in the hallway or at the bar. So I think if you attend IMAST, you're going to probably learn twice as much as just watching the video afterwards. And I remember in business school, they taught us that the most accurate and up-to-date information is what you hear at the water cooler. And by the time it comes out, sterilized into email or video, you're not getting quite as much information or quite as fast. So the truth is, if anyone's worried about suffering FOMO from not attending IMAST, you should be worried about that. You will be missing out. Don't you think so, John?
Without a doubt.
What's kind of cool is IMAST has not been in person since 2019, right, Ahmet? That's 3 years.
Yeah.
And the real focus of this meeting is on innovation, what's new. So there's really all kinds of stuff that's come out in the last 3 years that we really haven't been able to talk to each other one-on-one. Now, at the same time, some of the stuff that was hot 3 years ago isn't so hot anymore. And we haven't had a chance to learn, well, why aren't we doing this so much anymore? So some of the interesting things will be Dr. Kabash from Hopkins is going to tell us why kyphoplasty, or the cement injections, aren't panning out so much. Now, the radiologists are still doing this a lot, perhaps because they can. So we have to tell our patients, well, why aren't we doing it so much? Why doesn't this work? Or some of the other things that looked promising at one point, like the Genesis system, kind of the non-fusion posterior systems, they were hot for a while and no one's using them anymore. So Dr. Bay is going to teach us, why aren't we using them anymore? Remember, for a while, everyone was doing anterior releases for Sherman's, and everyone was up at the mic saying how great anterior surgery was for scoliosis. We're not doing that anymore. We should discuss, why aren't we doing those things anymore? Last year's IMAST, this was one of the best attended sessions with all kinds of discussion. Dr. Stefan Parent, do you have any comments on this? I know you're going to be moderating this with me.
No, I know. I really look forward to this session. I think it's placed on the Saturday, right? So it's just before people go back home, and they will have had the opportunity to discuss and see new things. But this session is really a highlight. Why are experts? How can experts tell us why they're not doing something, or something that they started with the idea that they would be changing the world and then not using it anymore? So it's always a little humbling for the speakers, but it's also great to be able to hear about this. So I totally agree with you. I think it's going to be a great session, and it's going to be at a nice time during the meeting. So it's going to be a good time to discuss it.
You know what else is kind of cool? The session on enabling technologies. Like when I do a scoliosis case, it might take about 60 seconds to bend a rod, but other people are saying we should spend more money and get custom pre-bent rods. I want to hear the debate on that back and forth. And people have been promoting robots for years, but a lot of the papers coming out now say, well, robots really don't decrease complications and maybe increase the time. So I want to hear, not only at the podium, people say the real life experience, but maybe catch people in the hallway afterwards and say, okay, what are you really doing? What do you really think about this?
Yeah, so we have also something new this year. One of this year's newest addition is that for the first time, I believe there will be 2 sessions where innovations related to adult deformities will be discussed jointly by AANS and SRS members, organized by SRS AANS Task Force. So one of them will be the session on neurological concerns in spinal deformity. So we are going to discuss here especially some neurological concerns that we might really be facing within the congenital scoliosis, like the diastematomyalgia and surgical timing when proposing deformity correction, and like KRE malformations and when to treat and how to treat, and also thinking beyond the dura, detethering versus spinal shortening for tethered cord. I think all these things are really big debates, and there's a big controversy, and I think these discussions in collaboration with our neurosurgeon colleagues, orthopedic and neurosurgeon colleagues, will help us a lot to advance, our information about these 2 topics. And the other one will be on advanced MIS techniques. This is very interesting because this will be a case-based video symposium, and there will be MIS TLIF, lateral ACR, prone lateral, and dual position with MIS lateral LF, especially for L5 S1 segments. So I think this is also this will be also one of the most interesting sessions in this meeting.
Hey, Ahmet, I'm glad you brought one of those things up. The idea, it seems as a profession, we are generally moving away a little bit from VCRs. People are realizing you could do a whole bunch of posterior osteotomies, probably with less chance of losing signals. But at the same time, someone's talking about, instead of doing a detethering, which to an orthopod sounds simple, and instead do a VCR, cut out an entire segment of the spine and shorten it. I've had a few patients who came up to me for a second opinion for that spinal shortening operation, and I don't really know anything about it. I want to learn about this.
Yeah,
same here. And David, you're also chairing the last session on video, right? Lunch with the experts. That's going to be another great session.
Yeah, that's one of my favorite ones, when you have the experts kind of take you through a case step by step. And then you get to ask them, well, why did you do this? Why did you do that? Larry Lenke's going to talk about his kickstand technique, which I've now adopted, and I think is a great way to get improved correction of pelvic obliquity, as well as decreased risk of it falling apart. And it's really nice to hear someone like Chris Ames talk about these cervical thoracic VCRs. Truthfully, I don't want to do them, but I want to see how he does it. And what about SI joint fusions? Are any of you guys on this podcast doing SI joint fusions? I've not done one.
Nope. Sorry.
This actually is a very interesting topic, and as a person doing also adult spinal surgery, this is a big question mark in my mind, and I always think that I'm missing some of the cases, very difficult to diagnose, and then very difficult to treat. And so in my practice, I have never done a SI joint fusion yet, but it looks like, especially in United States, this trend is coming. And maybe this will be a great solution. But anyway, so there will be, I think, good discussions about the SI joint as a pain generator, first of all, and how to diagnose, the SI joint as a pain generator, and also how to treat it, and whether fusion is really helping us for the low back problems in our adult patients. So I think this will be another very debatable, very, very nice session.
Well, I'll tell you what, I think it is debatable. I personally, as a tree-hugging pediatrician, have never once seen an SI joint help one of my patients. And I have seen an SI joint fusion lead to one of my patients' loss of bladder function permanently. So I think that this is a hot new operation, but I don't think it is without complication. I think we need to look at this one with eyes wide open.
Yeah.
And yeah, John, I'm throwing out some controversial things so people might actually listen to this.
No, that's my favorite part of these things and these meetings too, where you get to hear experts argue about stuff, especially stuff that they're not used to arguing about. So it's good that we bring some neurosurgeons on and bring some new procedures out so that people can take some new punches.
Yeah. So I really agree, David. That was a great session that you have started many years, last year or the year before, that the bandwagon I jumped off. So I really wonder, and sometimes, I'm just laughing, we will see some of these techniques that we are discussing right now as, patient improvement technology. Maybe they will be discussed in the, bandwagon that I jumped off 5 years later, so we will see.
You know what? It's an important thing as a parent to never pass up an opportunity to embarrass your child. So I should point out that my daughter has been lucky enough to match at Stanford for orthopedics just yesterday. So Dr. John Vorhies will be teaching my daughter spine surgery. So thank you, John.
No.
We'll try to do our best not to screw up her education too badly.
Yeah. And now I have to make her listen to this. Get all these young people on.
There you go.
So Stefan, we are chairing together the non-fusion surgery, the next level, advanced techniques and revision strategies.
Yeah.
So I like this title very much. Non-fusion surgical management of AIS. Improve your reality or lower your expectations. So I think this will be a great beginning to this session. So would you like to say anything about this session?
Yeah, I agree. I think that this is going to be a nice session. There's been a lot of talk at SRS level to maybe tone down a little bit the VBT Kool-Aid. And I think that's going to be a good reality check for everyone who's going to be attending this session. I think you're going to hear from experts in their field present cases and debate cases on good outcomes, what constitutes a good outcome or what they think is a good outcome, and also what constitutes a so-so or not so good outcome. And then taking those pink glasses and taking them off and maybe looking at the data a little bit more closely. So I think it's going to be a very well-attended session. The faculty on this one is just out of this world. It's just really great. And it's going to be very interesting to have everyone's opinion. So I would encourage everyone to show up for this one because it's going to be a great one.
Hey, Stefan, let me ask you about that. In a meeting recently, I saw a whole bunch of surgeons doing a standard selective fusion with posterior instrumentation, and then doing a anterior tether to the lumbar spine.
Yeah. Do
you worry that you're setting up this really long moment arm to put a whole bunch of extra stress right at the top of a VBT?
Yeah, I totally agree. I think I hear you very loud and clearly. I think that this is going to be an issue because we know that tethers will eventually break. And my concern, and I think that this is something that we all need to look at very closely, is to not only look at the 1 or 2 year results, but start looking at the 5-year results. And with like anything else, when things come out like this, people will have this great idea and say it works. And then maybe in 5 years, we'll be re-extending fusions in the back from a lot of patients. And my other concern is always to look at the sagittal profile and trying to understand what constitutes the limit of this. So there is some good information that we do have over time, but it's still a unclear path to me to what is the optimal sagittal profile for these patients, and are we changing that sagittal profile in the lumbar spine in a way that we go back maybe 40 or 50 years of the Harrington rod. So it's going to be a real challenge. We know how much we can change the sagittal profile from the back. I think we underestimate how much we can change it from the front. So it's going to be interesting down the road. And the lever arm question, no question that it's going to be an issue regarding tether breakages in the future, in my opinion.
Yeah, you know what, Stefan, I honestly just respect you so much for your honesty in this, because you're one of the leaders in the field, and you're also leading us to look at this in an honest fashion. So I commend that. But when we used to do lumbar scoliosis surgery from the front, the big thing was keeping lordosis. And you're right, if all we're doing is compressing in the front, we're taking away lordosis. And it does seem to be kind of the equivalent of the Harrington rod when you distract in the back and take away lordosis. So yeah, thank you.
Yeah.
I think in this session, so this hybrid surgery is also one of the topics, and we will listen to one of the champions, I think the Istanbul group, Dr. Hamzoğlu and his colleagues, about their experiences on that. I agree on that, but I think there will be a lot of discussions and debates related to long lever arm, whether it helps to protect tether or whether it causes tether breakages. So it will be a good discussion again. So I think one of the interesting sessions would be the one that we have, I think, started 2 years ago. Now it seems to be becoming a traditional session, and that is the early career surgeon session. So interestingly, one of the most attended sessions last IMAST meeting was this session. And so we are expecting, again, all the young surgeons, early career surgeons to attend to this session. And the topic will be mainly on planning. And the title is, I like the title, Plan Ahead, Don't Play by Ear. So I think this is something really very important for early career surgeons.
Absolutely, and the mechanics of how you go about doing that for a new case, a case that you haven't done before, a case that you might have only seen a handful of times in your training. I tell people, as a young surgeon myself, I tell people that I learned the most often from the surgeons I trained with who were not virtuosos, but attendings who are regular people, because they had to plan the heck out of their surgeries to have good success. And that's a more reliable approach.
Hey, John, if it's okay, I'm going to argue with you on this. I'm going to say that the virtuosos are the ones who plan ahead. Does that sound fair?
Well, I suppose that's your definition of virtuoso.
Yeah. Yeah, I hear what you're saying, right? But I think the scariest thing is the surgeons that feel they don't need to plan ahead.
Sure.
There's really nothing more dangerous than an overconfident spine surgeon.
Yeah.
I agree. Maybe one session that I'm interested in is it's also to appeal to all the ones that haven't made their mind on when they will arrive, is the Wednesday afternoon session, when the one that kicks off the meeting, cases and cocktails. I think this is another very well attended session. Usually we started this, I think it was in Amsterdam or in one of those earlier meetings, but this session is really just before your welcome reception. It makes sure that people are getting a little loose to talk about cases. We have 4 great sessions, so people can pick and choose where their poison is and start discussing. But it's going to be a real nice session to discuss. And it's also a place where you have really great faculty in the meeting and they are discussing cases, but it's also for you to bring cases if you want to discuss your own cases. So I think it's if you're not decided if you're going to arrive on Wednesday afternoon to attend this session or on Thursday morning, this is the one that you want to attend on early on. It's the front loading of this meeting is great. So you should be attending this session.
Yeah.
Yes, Stefan, for young people, they should know that Stefan is an expert on wine and you can learn from him. But yes, after you have a little bit of truth serum, that's when you really learn the most from the experts. I am so looking forward to having some wine and hearing some experts talk about disasters.
Yeah,
I want to be in that room.
Yeah. So I agree that this is we have started that in Amsterdam actually, the first one, and I just want to give a very brief description of the format of this session. So we have 6 tables. And all the young surgeons or all the participants are coming around those tables, and there is one table instructor who is a faculty, who is really an expert on the specific topic. So one faculty is presenting the cases, and the cases are discussed at the table, and then there is a discussion of all tables together of that specific case. So I think it really helps a lot. This learning format, I really enjoy it, and it really helps a lot for a good discussion.
I agree. It's one of the it's a nice session, and it really brings faculty and members together. So I really like that format.
Yeah.
I agree.
And why?
The other reason to make sure we're there from the beginning is the very top-rated papers are first thing Thursday morning, the White Cloud Award nominees. And something that has my attention is a double-blinded, randomized controlled trial showing that topical tranexamic acid does not result in reduced blood loss. Have you guys used that? I don't think I pronounced it right.
Yeah, it's interesting. We use tranexamic acid or Amicar in all of our AIS solution cases. We kind of went back and forth between the two, but I don't think we've ever used topical.
Yeah.
But it's something that's been studied in the joints literature, I think.
Yeah, we use it with every AIS case too, and I've seen some papers showing that high dose has a huge improvement over low dose. So I think that is something that most people use.
Yeah. And David, I don't know how it is in your practice, and Stefan, but as I mentioned before, it's sometimes really very challenging for me to manage the pediatric cervical spine deformity. And I think we have a session that first time in any of the IMAST or SS meetings, we will be discussing this issue really in much detail. So I think this is an interesting session. Maybe you would like to say something about that, your experiences with pediatric cervical spine deformity in skeletal dysplasia, trauma, or congenital anomalies.
Yeah, I think you raise a good point. Even someone that's doing many pediatric spine cases a week probably aren't doing that many C-spine cases. None of us do that many pediatric cervical spine cases. And this is exactly the type of thing that we need to learn from each other. We need to pool our experience, hear people talk about it, then more importantly, talk in the halls. Okay, what did you really do for this? What do you really, and actually I have a situation, a kid who was treated sane elsewhere, C1, C2 rotatory subluxation has been out for 10 months. Is that somebody that you want to reduce intra-op or you want to reduce pre-op?
Yeah.
I don't know. I'd like to have people's advice.
No, they are tough cases. And I think that My experience with these is that I trained as a pediatric orthopedic surgeon, but also as a spine surgeon, and I did adult for a long period of my time. And the experience I gained from the adult world is that made me less fear the pediatric cervical spine. But they are challenging cases, and it's just a discussion around them. What you do, what's the timing, what do you fuse them, do you not fuse them, do you instrument them? Some of these cases are really hard to instrument. So it's I agree. I think it's going to be a great session.
I wanted to mention this one more thing that we were talking so much about the bandwagon session. I can't remember which meeting this was at, but it was a pre-pandemic meeting where there was a bandwagon session, and Charlie Johnston introduced it, and he got one of the typical Charlie Johnston jabs in there, where he gave a lecture about the etymology of the word bandwagon. I'm not sure exactly how historically accurate it was, but he said, "I wonder if you know what the bandwagon is. It was a wagon or a trailer that would drive around with a parade or a circus, and clowns would jump on and off the bandwagon. So without further ado, I'd like to present these bandwagon riders and tell you a little bit about their experience with some advanced techniques."
So we have to give credit to Dr. Lindsay Andrus. She is the one that I think came up with the bandwagon session for one of the early onset scoliosis meetings.
Yeah, that was it.
So great, I copied it for this meeting.
Nice, good move.
Great. Yes.
So thanks, Lindsay.
Thanks everyone for joining us for this latest episode of Scoliosis Dialogues, and we look forward to seeing many of you in person or virtually as you're able at the upcoming IMAST meeting in April 6th through 9th in Miami, Florida.
Have fun, guys. Break a leg.
Hey. Have a nice weekend.
Thanks.
The Scoliosis Research Society is a nonprofit professional organization made up of physicians and allied health personnel. Their primary focus is on providing continuing medical education for healthcare professionals and on funding and supporting research in spinal deformities. Please visit srs.org for further information.